Okay, so thanks everybody for joining us. We are representing the UCLA Patient Family Advisory Council for the Resnick Neuropsychiatric Hospital. So on this call today, there's going to be me, and you're going to hear from Martha and Robin, who are also patient family advisors, and Steve and Monica, who are on the staff at UCLA. And we're going to tell you a little bit about the PFAC and what we've accomplished over the last couple of years. So we'll start out with how this PFAC was formed, the composition of the PFAC, the objectives that we came up to, and how we manage and run the PFAC, and then talk about specifically, give you guys some good ideas on what some of the initiatives we've undertaken and the successes that we've had as a PFAC. And remember, I know there's a lot of people out there, they may or may not be on a PFAC. We are specifically the neuropsychiatric PFAC. So we deal with behavioral health issues. And at the end, we'll tell you why it's important to have PFACs at your healthcare institutions. Okay, so back in 2014 was when we formed our PFAC. And UCLA has an Office of Patient Experience, and they collaborated with the staff at the Resnick Hospital at UCLA and saw that there's a need to incorporate the patient voice in the decision making. So just to give you an idea, I think UCLA took it really, really seriously. We are one of 8 PFACs at UCLA. So there's a lot of different PFACs at the hospital. For example, we're mental health. The Children's Hospital has one. Neuropsychiatry has a PFAC. There's a Spanish language PFAC, and many others. So they're taking it serious that the patient and family voice should be incorporated into some of the issues that go on in the hospital. When we formed the PFAC, we developed a charter, and in that charter, we had a mission statement, and we put down what our objectives are going to be. And we have a copy of that charter, so I encourage anybody, if you want to get a copy of it, we are happy to send it to you. We've shared it with lots of other people that wanted to start up PFACs, and I think it's a good starting point for you if you're interested in starting a PFAC. For the people that weren't on staff, so for the patient and family members that are part of the PFAC, we got some training on HIPAA because, we're just civilians, so we didn't know about all these issues that relate to that. And after we went through training, we were awarded badges so that we can get around the hospital and walk around freely. And it's also kind of like it gave us a sense of belonging as well when we've got those badges. So our PFAC is focusing, it focuses on both inpatient and outpatient programs. So we're trying to tackle 2 things and trying to make a difference and improve the patient and family experience there. We meet monthly, except one time in the summer and at Christmas. And a lot of people ask me like, oh, how many times do you meet? Sometimes we have phone calls off, that are not part of the formal last week of the month Wednesday meeting. But we do, so we communicate outside of that as well. But there are 10 formal in-person meetings. Before COVID, they were in person, now they're on Zoom. Okay, so the PFAC is comprised of about 14 people. It changes all the time. So the nice thing about it, so it's basic. We try to get a mix of 7 patient and family members and 7 people that work at UCLA. And the people that work at UCLA they're the decision makers at UCLA, which is, I think, really critical for a PFAC. So if we're working on some sort of initiative, we can rely on the people in the room to give us a go or no go right then and there. They're senior enough to make these real important decisions. So we have a senior clinical director, which is Steve, and he's going to be talking to you later on in this. And then there's patient and family members. We have chief of nursing, chief of social work, a lot of chiefs, a lot of people, and we tried to get different functional areas that represent all parts of the hospital. And because of that, I think we have a really good representation of all the different functional areas that are going to impact the patient and family experience. So you can read about like who we have on the team. The important thing is that we've got people that can help us make decisions, and we have people that can help us execute on those decisions, like Monica, who you're going to be hearing from later on as well. So when I think about best practices for a PFAC, that's one of the things I always say. It's like have the decision makers in the room and the people that can execute on that to help with any initiatives that the PFAC may be doing. Okay, so I'm sure all of you have heard the expression, nothing about us without us, and that kind of guides a lot of what we do. We really believe it. It's if there's going to be something that's going to impact the patient or family experience, you need to have the input of the patient or the family member in that decision-making process. So nothing about us without us is kind of a mantra that I think all patient family advisory councils should have. When we put together the PFAC, we kind of said, where do we want to focus? What are we going to tackle? What are all the issues that are coming, you know, that are important to us? And believe me, there's like a laundry list of stuff. And we kind of boiled it down to identifying opportunities that we can help for process improvement. Obviously, we want to improve the overall patient and family experience. Promoting and improving communication is key. And the key thing also is to be solution oriented, right? So when I think about a PFAC, it's kind of like they serve two functions. The first function would be, and this is the typical function, it's like you're like a focus group. So if somebody has a problem or an issue, they said, oh, let's talk to the PFAC and let's get their opinion on it. And that's a great purpose for PFAC, and we love to be a focus group. But we like to also try to be more hands-on and say, what are some initiatives that we can create that is going to help drive the improvement of the PFAC? So essentially, what can our PFAC do to support wellness and recovery for patients and families and meet our objectives? So we tackle these issues from not only like, okay, we can just be a focus group and be passive about it, but also like, what can we be active about, and what initiatives can we work on that is going to make UCLA Health successful? And an even simpler way to think about it is like we focus on improving the patient-family experience. We focus on improving patient safety and improving ways that people can navigate the system. And those are kind of the buckets that we work from to help execute on everything that this slide is showing you now. Next slide. Okay, so we're going to go into a lot of detail on a couple of these initiatives. So I said there's the focus group part, but here are the initiatives that we actually worked on. And Martha's going to come on and tell you about a storytelling program that we rolled out that has a phenomenal impact on people at UCLA. And it's a great educational tool that we developed to help healthcare providers. She'll also tell you a little bit about this HOPE logo that we incorporated all over the hospital. But we've also worked on initiatives where, you know how there's tons and tons of paperwork that you're handing to patients, and we worked on rationalizing that and making it a little bit better. And in the mental health community, there's the emergency department is, even though our domain is inpatient and outpatient, most people that are inpatient are getting there through the emergency department, and it impacts the patient and family experience. And we've worked with the ED regarding areas for improvement. And so we try to work on projects that are going to help improve the patient experience, like conducting a safe discharge rapid improvement project. And we had a full one-day meeting where we tried to figure out and brainstorm ways that we can improve safety at discharge. And another big project that Steve and Monica are going to talk about is an app that we created that's going to help patients and families with information and help them navigate the system essentially. Next slide. Okay, so let me pass it off to Martha now. Martha's also a patient family advisor like me, and she's going to give you some real specifics around just two of the initiatives that we've worked on that'll help you understand what our PFAC is trying to accomplish.
Thanks, Glenn. Good morning, everybody. Can everybody hear me okay? Yeah, great. So as Glenn mentioned, one of the things we do as a PFAC is we brainstorm ideas of things that our PFAC can roll out that will assist in the patient family experience within the confines of a large metropolitan hospital. So sometimes we'll come up with these great ideas and the look on the administration's face kind of tells us all, which is not going to happen. But what we do is we spend a lot of time talking about what was our personal experience as either a patient or a family member moving through the Resnick community. And I am the parent of a daughter, Charlotte, who is now 21, who was an adolescent and went through inpatient, outpatient, partial program, utilized Resnick quite a bit. So often what we'll do at our discussions is we'll think about things that affected us while we were at Resnick with some hindsight of having had a little time out. Some of us are current patients, but most of us have had a period of time where we can kind of let things synthesize about what it was like to be part of Resnick as a patient or family member. So one of the things that kept coming up in our roundtables was this sense of hopelessness when we were dealing with hospitalization, either for ourselves or our family member. Usually most of us had been through months, if not years, of disruption for ourselves and our families due to mental health issues. And we were pretty depleted by the time we got to Resnick. In whatever program or capacity we were utilizing Resnick, it often sort of felt kind of like both the end of the road and the last chance at recovery. Not that that's an accurate emotion, but that was an emotion many of us did feel at the time. So it was really hard not to fall into a negative spiral on a fairly regular basis. Many of us had come to Resnick, as Glenn mentioned, via the ER, or the ED, which is in and of itself, we could have a whole hour on that, but there's an inherent trauma that develops when a mental health crisis unfolds in a medical emergency room. And it's really one of the worst adventures on a long list of pretty lousy psychiatric experiences. So many of us wind up in Resnick having entered through the ED. What we craved, which was made very clear to us afterwards, and we had time to sort of process our experience, was a message of hope that could represent a light at the end of the tunnel, with us usually having no idea how long or dark that tunnel might be. So our PFAC came up with the HOPE logo, which you're looking at right now, and the acronym, helping our patients every day. And the visual of the tree was sort of what we considered a positive branding experience for Resnick. The HOPE initiative was a really collaborative event, and we met with marketing often, and we navigated the requisite red tape that any large hospital will face when trying to implement a new branding. And we got to explore our own goal for the HOPE message as we worked on the project. What exactly did we want to do with this? So after we got all our marketing materials approved and printed and ready, we launched an awareness blitz, and we finalized everything. We unveiled the logo and the concept to the staff too, and planned presentations. And it's now used on Resnick paperwork, messaging is on the name tag holders that Resnick staff uses, and it's amplified in large poster type wall hangings that are located throughout Resnick, including the vestibule area, which is an area where family members would sit waiting to be admitted into the locked floor when they were visiting their loved ones. And what we were looking at was a gray wall that just kind of really mirrored exactly how we felt at the time, which was pretty gray and bleak. So the long-term goal was also to create a culture within Resnick that incorporates the HOPE language and the vision in all its interactions, with the eventual result being improved outcomes for family members and patients. We look at the HOPE branding as a physical manifestation of our work as a PFAC, which is to affect change and optimism for those who now utilize Resnick for their mental health care. So it seems like a small thing, but really it totally exemplifies what we do as a PFAC in a great visual. So we're very proud of that. And then on our next slide is our storytelling program, which is something I'm so enthusiastic about. So during also our meetings, we would brainstorm ways that how could we effectively educate the staff and the faculty about what it's like from the patient or family experience in a really accessible format. How do we reach a large number of audience? How do we express the experience in a way that's meaningful and personal, but also valuable? What can we deliver out of that? So right now we have 3 members of our PFAC who currently present the storytelling program. It's myself, parent of an adolescent who's now an adult who'd gone through many of the programs, Glenn, who's had two kids in and out of the programs. And then we have another PFAC member who's an adult who she herself utilized an intensive partial patient program. So she speaks from the patient perspective, because the perspectives can be kind of different. Like what is important to an adult in an outpatient setting can be really different than what it's like for the parent of a child with other children at home who's maybe, inpatient at Resnick. So we try to keep in mind that just because our experience is the one that we're telling, it isn't the only experience. And that's something we keep in mind too. So we've presented to hundreds of participants across a broad spectrum of departments, including social workers, psychologists. We've done OT and RT. We've done nurses. We are part of the new hire process for nurses at Resnick. So in their orientation week, we come and speak or do it via Zoom. So it's something that's now embedded in the new hire system. We've spoken to medical students, residents. We even presented to the staff in finance and collection so that they can understand what the person on the other end of the line might be going through, because we're just a voice probably complaining about a bill. But it just sort of helps to personalize that experience. We break our story into 3 specific timelines: before, during, and after hospitalization, so that staff gets to see that there's a whole other lifetime before and a whole other lifetime after, and then this tiny little part where we're actually in-house at Resnick or using their outpatient programs. And some of us, like I said, have had months or years of mental health issues before we wind up at Resnick. And on the flip side, most of us will likely have months or years of issues before we kind of can do the healing that needs to be done with mental health. We emphasize key takeaways for our listeners with concrete examples of how they can incorporate those takeaways in their daily practice with patients and or family members. Some of these takeaways include the ideas that, 1, we have a palpable need for compassion and empathy. Seems like that would be obvious, but sometimes it's not in a hospital setting. We are yearning for a sense of hope, and we look to them for reassurance. They're like our security blanket. They are usually seeing us at our absolute worst, and we have unrealistic expectations of what they can do for us and our family. Really, it's fix it, fix it, fix it. I don't care how, I don't know, care what we need to do, but you need to fix it. That's what we're thinking. We are in a state of shock and have experienced probably a fair amount of trauma before you even get to Resnick. So we have a difficult, basically almost impossible time processing information. So we remind them that they need to tell us once, tell us twice, and then tell us that they told us so if it's an important piece of information that we need to retain, and most preferably also have it in writing, and then remind us that we have it in writing. Then the other thing too that we talk about is we're suffering from the ongoing stigma of mental health illness. And really Resnick staff needs to be reminded that there's challenges, particularly in certain cultures, when you or a loved one are hospitalized or utilizing a program for a mental health issue. We always kind of say, like, if it were cancer or, a heart transplant, we would end up having people dropping casseroles at our house. We would have people offering to help with other members of the family. We'd be getting bouquets of flowers. Instead, we often, we kind of back ourselves off and become very insular, very embarrassed, ashamed. I'm a person who will tell people anything. And when our daughter was hospitalized about 5 years ago, I didn't tell anyone. I didn't tell my own mom. We didn't tell her sister. The shame, it's overwhelming. So that's another thing that differentiates a psychiatric hospital stay than a medical hospital stay. So we also have time for Q&A. Our presentation lasts about an hour. And so usually it's one or two of us who speaks at a time, and we deliver our stories. We've also done a PFCC conference like this. We did a presentation where we actually did our storytelling as if we were telling it to the Resnick audience. And it was really well received, and we got great feedback. And a lot of people came up to us afterwards and said, you know, this is very similar to my story. So there's a lot of connection through this. So what I'm going to do now is I'm going to give you an extremely truncated version of the presentation that I would do about my daughter, Charlotte. So it's really quickly, this I spin out into an hour, and Glenn is constantly looking at his watch and trying to get me to shut up, but I'm going to do it really quick. So we have a daughter, Charlotte, who's now 21. She's an international adoptee from Guatemala. She was adopted at the age of 7 months and had spent her first 7 months in a foster care home in Guatemala City. When she joined our family, we had a biological 5-year-old named Grace, and 2 years earlier, we had lost an infant at her delivery named Ellis. So Charlotte was already coming into a house with a sibling dynamic that was, you know, somewhat complicated. When we did our adoption proceedings, we were told that we needed to be ready for a host of mental health issues, starting with ADHD, 99% chance that an internationally adopted child would have ADHD and be diagnosed with that. Also, reactive attachment disorder, sensory integration issues. She would have probably language issues and some learning disabilities. And we were like, whatever, we're going to love her so much that none of that's really going to matter, because this kid is going to be so showered in love that it will compensate for any of these things that they're trying to scare us about. And I was also kind of like, yeah. I didn't process that information very well. So then Charlotte came home, and she was diagnosed with ADHD quite early on and did have sensory integration issues and some attachment disorders. But we were like, you know, we tackled that as it came along with the advice that we were given by specialists. By the time Charlotte got to middle school, her issues had amplified to the point where we were in a real red zone. She was struggling with identity. She was promiscuous. She was self-medicating. She was lying and stealing and acting out and had rage disorder, a lot of trouble at school, hated us, and we were really in a very dark place. And then it became apparent to us that Charlotte was suffering from an entrenched and very, very, very bad cutting habit, to the point where she was really scarred up and had done a great job hiding it from us. And I think also maybe we didn't want to see it. So in 9th grade, right before Christmas in 9th grade, Charlotte told us that she was planning to kill herself. So at that point, she had only been seeing a private therapist once a month for talk therapy, which was really not helping, if anything, maybe making things worse, because we sort of thought like, well, it'll get taken care of there. So that was our first exposure to UCLA. Was we walked into the emergency department with a very, very, very psychologically unstable 9th grader who had suicidal ideation. She was put on a hold. It was a terrible experience. I don't probably need to go into great detail about what it was like, but let's just say in my mind, I was thinking it doesn't get any worse than this. And then when Charlotte was admitted to the 4th floor, which is the adolescent wing at UCLA, and they pushed her in a gurney and those doors shut behind her, I thought, well, actually, it doesn't get any worse than that. And then she was only inpatient for 5 days. We had an amazing experience at UCLA. We had setbacks, we had optimism, we had revelations, we had despair. We cycled through a lot of emotions, but her stay was only 5 days and she really needed about 5 months. So she was discharged. She went through some partial programs, outpatient. I did some programs with her. We saw, up and down recovery. But ultimately, about a year and a half after her hospitalization, we realized that Charlotte needed something long-term, and a psychiatric hospital was not actually the answer, because it wasn't as acute as it had been, but it was definitely, she needed some help. So we put her in a wilderness program to begin with, where they came and kidnapped her from her bedroom, which, was traumatic as could be. She spent 3 months in a wilderness program. And from there, she went to a residential therapeutic boarding school for girls with complex psychiatric disorders in Utah. Was there for about 2 years. Did a lot of work. All of us did a lot of work. She graduated from high school in the program. She's been home a few years now. She shows no signs of borderline personality disorder, a very mild case of anxiety, which I have to say, I think right now I have more anxiety than her just being alive in the world. And she lives independently. She sees a therapist every other week just to check in. She's extremely stable. We haven't had any mental health crises in the last few years since she's been home. And we worked hard to get her where she is, but without the resources and the help from Resnick, I don't think we would have had the successful outcome that we do have. So from our ongoing experiences, we inform and teach the current Resnick staff on what it's like to be in our shoes. Little details too, which I didn't get to go into too much, but sometimes those little details really sink in, that Glenn and I and our other partner in the PFAC can just remind them of these tangible moments. And throughout it, we would do the takeaways. So by telling our story in this format, we can really engage the audience in what our paths have been like and how instrumental they can be in helping us with all the positive outcomes. So it's really been an honor to be part of this Resnick program. I think it's one of the most effective ways that our PFAC has been able to participate in a wide-ranging education to the hospital audience, and we hope to continue to roll it out as often and long as we can. So thank you.
And this part is actually going to be presented by Robin Mandelberg. Robin?
Hello. Hi, everybody. I'm Robin Mandelberg. I am on the PFAC committee. PFAC stands for Performance Improvement and Patient Safety Council. In other words, quality. Starting with a quote, Henry Ford says, "Quality means doing it right when no one is looking." At the PFAC, I represent the PFAC. The PFAC deals with the nitty-gritty of the hospital. How many linens to order, sanitization, the sheets are too scratchy, the soup is too hot. The meetings are very data-driven with charts and graphs. Well, the PFAC reaches out directly to patients and their families and makes their subjective experience more positive. PFAC is what the hospital does on its end to achieve certain standards of care, including maintaining an optimal and safe patient experience in compliance with certain evaluations. We receive magnet status. PFAC is composed of nurses, social workers, OTs, RTs, and high-level administrators. There are no MDs except the faculty advisor. Data are presented along the lines of infection control, such as hand washing and sanitizing, and patient safety, such as falls or contraband confiscated. We have reports from nursing, such as medication administration, vital signs, day-to-day interactions with patients, and medication education. Reports from social work about running groups, family care, and discharge plans. Top administrative reports about the benchmarks, finances, and committee oversight. Some of the projects that we've been working on in PFAC is a Good Catch Award. So once a month, a prize is awarded to a nursing staff who has caught something that isn't as it should be, such as a medication error, such as a patient who has a Kindle with access to the internet and no one knew that she had access to the internet. We also work with pet partners where the dogs come onto the unit. The patients love it. It definitely boosts their mood and their affect and decreases their anxiety. And then we have a rooftop gardening project where the nurses actually cultivated a garden on the top of the hospital where the patients can work and plant and get together, giving a sense of purpose and activity for the patients and building relationships between the patients and staff. We have a hand washing initiative just to track that for sanitary reasons, and a fall precaution such as extra rails and shower safety. I end with a quote by Margaret Mead. Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it is the only thing that ever has. Thank you.
Hi, good morning, everyone. I'm Steve Cohen. I'm the clinical director for the Resident Hospital and the outpatient programs. First, I just want to thank Glenn, Robin, and Martha for just the amazing work they do on our committee. It's really an honor to participate in this committee, and it's, you know, I'm in a lot of meetings throughout the day, and this is by far my favorite meeting. We really have the opportunity to make a positive impact on the patient experience. And as you can see, just the projects that have been discussed so far have been really amazing and impactful for our entire patient and family population. So I'm going to talk about our app that we recently rolled out. For a little bit of background, prior to working in the Department of Psychiatry, I was with the Department of Neurosurgery. So I had some experience in building an app. We built a similar app for neurosurgery that was actually a tool to help patients prepare for surgery. So it gave them a timeline and reminders on their phone that would, for key steps leading up to their surgical date. So we took the same concept and the same framework that we actually built, and we were able to quickly develop an app specifically for the resident hospital and our outpatient programs. So we actually partnered with Upper Campus. So there's a group called the Office of Information Technology that is a couple buildings down from ours. And we had this really successful rollout with the neurosurgery app. So we re-engaged that same team, and they helped us, you know, just set up the actual platform. If you were to build an app and go to the general market, I mean, an app can run you $50,000 to $100,000. So when we first built our neurosurgery app, we invested about $35,000, $40,000 total, and that was building an app from absolute scratch. And that was working directly with the UCLA team. Because they had already developed this amazing platform that essentially allowed us to build our own app, they built an app builder, we were able to go in and just have access to the platform and build it from scratch ourselves and input the actual content. And so the cost to our department was only about $5,000 or $6,000. And then there's an annual fee where that we pay, and that's how they manage the server and you know, all the technical issues that goes into just the annual management of the tool. But in terms of the actual cost, it was very minimal. And then you can see here that the team member, the key to the success for this app was really just the number of people and the wide range of skill sets that we brought to the table. So we had people from administration, physicians, nurses, residents, social worker, rehab, occupational therapy. It was about 20 people in the room that we got together, and we had a very focused series of meetings. We were meeting every other week. And we basically went through, identified what information was available, what information was lacking, and assigned those gaps to specific people, specific stakeholders. And we quickly gathered all this information and updated and refreshed some of the older information. We started the project in March of 2019. We had this fast track bi-weekly meeting where we really focused on just quickly getting and updating information. And Monica can go into how the app was actually built, because when I say, you know, we built it, Monica did the heavy lifting. She was really amazing and became an app builder guru. And you can see that from March until October 1st, in just about 7 months, we gathered all this information, updated it in the app, and we actually went live on the Apple iTunes site. And so patients were and families were able to download the app immediately. And so it was an amazing quick turnaround and has been a huge success. One important factor for the success of the app was educating our own team about the app and how they could use it as a tool to help the patients and their families. So after the go live, we went and started giving demonstrations to the different stakeholders, to the different nurses, the residents, the different staff. We also started publicizing it. We created these handy postcards with simple information on how to access the app. And we had these postcards available in the admissions packet on all the floors, so throughout the Resnick Hospital, as well as in our partial and outpatient programs. So the postcard and the app is front and center everywhere in all of our different locations. And so that was just key to getting the word out and educating our own team on how they can best leverage this new tool. You can go to the next page. So this is the high level of some of the key things that we added to the app, and Monica's going to go into a little more detail. But this is really an education and orientation tool for family members and for patients and their family members. I'm not sure if everyone's aware on the call, but patients don't have access to a phone or an iPad when they're in the locked unit, and so obviously this isn't going to be something that they're going to have access to. But it is going to be very helpful for their family when they're doing research on the process. Everything from what to expect when they're visiting their family member, what they can bring and what they can't bring to the floor. So it's really soup to nuts overview of the outpatient programs, the partial and intensive outpatient programs, as well as Resnick. So it's really the full breadth of the medical journey that these patients and families go through. There's some slick things like a Google search function. You can see it's a nearby button, and that allows the patient, or the family member who's probably spending a lot of time on campus to quickly find a hotel or a restaurant or somewhere to get a simple cup of coffee. So, things that you might not think about when you're going to a hospital, but when you're finally there and you have a lot of downtime and you need these basic resources, they're there at your fingertips. We also have a lot of tools that the social work team provides to patients and family members when they're in-house. A lot of this information has been historically on paper. That's just the easiest way for patients to get it. But now we have mindfulness and care provider resources all baked within the app. And so everyone is going to have access to this information wherever they are. And so it's really great because we're getting away from paper, and because this is all baked into an app that we have access to updating it, we can quickly update and refresh any of this material as things progress. And I'll kick it off to Monica, who can go into a little more detail.
Thank you, Steve. So the next couple of slides, I will show you screenshots of the actual app, but feel free to download the app in the Google Store or Apple iTunes just by searching UCLA Psych, a little marketing of our app there. And it's free to download, of course. The first screenshot is the home page. And as you can see, there are buttons that are our main categories. For example, hospital stay, PHP and IOP, which stands for partial hospitalization program and intensive outpatient programs. Team members, which describes, what's a resident, what's an attending, what's a social worker, what's a OT/RT. Patient care services button, which comprises of information on inpatient, outpatient, partial and outpatient programs, and buttons for the ECT, electroconvulsive therapy, and TMS, transcranial magnetic stimulation. And some of these buttons are featured in, for example, ECT and TMS are featured under patient care services, but we just wanted to duplicated for easy access. Hospital services, which features the, what's the Wi-Fi or where's the gift shop. And then planning for care after discharge, which talks about tips for a safer home, what's uh, different kinds of facilities, like what's a board and care facility, what's a SNF, and another button is the education, which links out to different helpful websites for patients and families, the relaxation and coping, the nearby button that Steve was talking about, and then caregivers and families, which features some more resources for caregivers and families. And on the bottom is really helpful. We have the home screen button right here, which takes you back to the home screen. We actually have a notes button where the user can take notes, save it, or take a picture if you're talking to a doctor, or you want to make sure you save a picture of something, and it just reminds you to talk about it when you see your doctor or your provider. And then it also has a My Chart link, which is our medical records link, which is the UCLA chart. And it's another app that the patients can download. And then the last button on the bottom is the Lifeline, which is the number for the suicide hotline, and it links you out to that web page. The next one is the hospital stay and information on medical records, contact and location, and then patient rights and responsibilities. The admission section has all of the admissions information on each of the unit, for North, for West, for East, adult inpatient psychiatric units. And then the cool thing about this app is it actually has the most updated schedule for each unit. For example, what are they doing on Monday at 2 o'clock? They're having a group therapy session. So, which is something handy, and you don't have to get an actual paper anymore or request it. You can just see the schedule on a click of a button on the app. Again, patient care services, we have information on what's a partial and IOP program, information on ECT, team members, planning for discharge, which talks about the most important thing. A lot of the patients want to know, suicide safety planning, discharge instructions, and planning for care after hospitalization. Again, more tips for families and friends, information on different facilities, and one of the awesome pages that we created was the relaxation and coping, which talks about guided meditations, more websites that are helpful for patients and families, dog therapy, and then useful apps for patient and families. For example, we have apps for relaxation, we have apps for anxiety, we have apps for yoga, just different apps that are helpful. And then this is the suicide prevention hotline that I was talking about when you click the bottom link, and it shows the information or the phone number for the suicide prevention hotline, as well as the website. And then something cool about creating the app is how to track the success of how many downloads during the duration of any time. For example, the App Store Connect app analytics shows how many times the app was downloaded. So between September 1st to August 24th, there were 540 units or 540 uploads, and it shows you actually where those users are from, which is interesting because we have 21 users in China. And also for UCLA Psych in the Google Play, it also shows you how many times Apple or Android users have downloaded the app. And now I'm going to kick it back to Glenn.
Well, this is the end, so I'm pretty impressed that I was checking the participants and we only lost one this whole time. So thank you guys for all staying here. I really appreciate it. Also want to say hi to Lisa. I saw that you were on, so hi, Lisa. Okay, so why are PFACs important? So this is a list I put together. I actually put this together with the help of Libby, in fact, who gave me some guidance on this a while back. A lot of the things on here are pretty self-evident, and I'm going to leave it to you guys to read this list, and obviously you can download it later. I just really want to point out one of them, and which is the third from the bottom, which is bolstered client interpersonal functioning and family relationships. So one thing you got to know, and it doesn't matter if you're for mental health or some other hey, Monica, fix that page. It doesn't matter if you're a mental health or at the hospital or inpatient or outpatient for any other ailment. What happens is that you're a caregiver when your family member or you come home, and having the interpersonal skills and understanding what you need to do when your family member or as a patient when you come home is so important. And I think that's one of the things that carries across everything we do is improving communication, so that when someone comes home from the hospital or even from an outpatient setting, they know what to do when they come home, because caregiving is also an important aspect at home. So having said that, that's our presentation. We're open for questions. And on the next page, you'll see all of our emails are there. So if you have any questions, feel free to email any of us, and we're happy to answer or respond to your emails with anything we can do.
Great, thank you. So if you have any questions, we do still have a few minutes. Feel free to enter those questions in the chat, or you can come off mute and ask your question verbally. Give it a few minutes.
This is Teresa from Dayton Children's in Ohio. I do have a quick question for you. We are trying to incorporate some of our behavioral health parents onto our hospital-wide advisory council. Our inpatient behavioral health unit is still in its infancy. It's about 1.5 years old. What would you suggest be the best way to approach a family? Because I know, as a parent myself of a couple of children who have experienced mental health issues growing up, I want to make sure that I'm cognizant. Some people, as Martha said, are embarrassed, right? Because their child was inpatient. So when I make that phone call to them, what do you think would be a great conversation starter to open that door?
So
It's a Martha question.
yeah, so that's a really good question. And I'll tell you how we do it at UCLA is that actually the social workers are asked routinely to identify parents, family members, or patients that they think would maybe be a good fit for our PFAC. So we don't actually, as a PFAC, approach people ourselves. Because I agree with you, and I've even had friends who've gone through UCLA, and they have no interest whatsoever in, like, that time is over for them and they're moving on. And I think too that it's important that you find members who don't have access to grind, who are not monovision about something that happened to them. And also, if it's a general PFAC and not specifically behavioral health, but you're going to include other people, you really want someone who is enthusiastic to be there and a good listener. So I would suggest trying to get referrals from social workers or people who have dealt with anyone who's maybe been inpatient. And also for us to, a little time out was helpful. I didn't have tons of time out. Charlotte was still really struggling when I started, but you know, that period of growth afterwards has a lot of ups and downs. And we've had people, I feel, who maybe have left the PFAC because it just, they were still too entrenched in the trauma of whatever they were going through.
Right,
But I
agreed.
think that the best approach would be to get guidance, get maybe a list, and then really just approach them with, you know, I think the social worker would maybe know. I was actually contacted by the social worker first, and she said, would you be interested? And that might be, if you have a way of doing that, and then that doesn't put you in the hot seat of like maybe making somebody upset.
True, right. Well, and I know I do a lot of my referrals through staff members,
Right.
but I think behavioral health, we really need to be more cognizant, you know, and you're right. Families who have children with any sort of chronic or mental health issue, we're great at compartmentalizing, and we
Yes.
just want to move on.
You know, we have one of our wonderful PFAC members has 3 children, all of them are medically fragile and also have psychiatric conditions. And she's overwhelmed. And it is a whole, I do think that having the medical component adds an arena that those of us on the PFAC now can't really even comprehend. But I think that the right person would not be somebody who would be upset at being asked. And kind of that's your answer right there.
Yep. Okay, great. Thank you.
Great, thank you, everybody. I'm going to put one question in the chat for all of our participants. What is one idea or insight you had from participating in this session? We are asking all participants in all of our sessions this question, and we'll be using these ideas in the final action planning session today, and share these also as an output to the conference. So go ahead and just enter one idea or insight you had into the chat here. And I'll give you all a few minutes to do that. Thank you.